From the American Academy of Pediatrics.
Congenital heart disease is the #1 birth defect in children, affecting nearly 1 in 100 babies in the U.S.
The AAP has a new algorithm for identifying infants with critical congenital heart disease before they leave the hospital.
Yes, we detect a number of cases of critical congenital heart disease, but we're also, detecting a lot of other types of diseases that, previously may have gone missed.
Plus, new research shows when Black families talk about potential police interactions, children feel less stress.
This conversation is so critical, but is not a natural conversation and is something that parents and caregivers really need to prepare for and recognize as an ongoing discussion with their children.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a conversation about new recommendations for CCHD screening.
One of the best teaching moments I had in the NICU was a baby with a failed critical congenital heart disease, or CCHD screen, who transferred to us on day of life 2 from the Well Baby Nursery. And the baby looked like they had some acrocyanosis, which is really common in newborns, and they were otherwise perfect on exam and did not have a murmur.
Okay, baby in the first few days of life, maybe some cyanosis, no audible murmur, but fails the CCHD screen. This feels like a pediatric board's question, I'm not going to lie.
Do you want the x-ray?
So can I see the x-ray, please? Can I click on the image? I'm running through the causes of cyanotic heart disease in my head using my fingers with that handy 5-finger mnemonic for CCHD.
And I wish our listeners could see him flashing his fingers
waving
here.
at you. But I'm going to go with total anomalous pulmonary venous return, or TAPVR, all 5.
Yes, David. I'm impressed, and I wish we could spend this whole episode just talking about TAPVR and your thought process there, because it's such an interesting physiology. But the guest we have today can lead us through so much more about screening for congenital heart disease. It's Dr. Matthew Oster. He's the first author on the clinical report, Newborn Screening for Congenital Heart Disease, a new algorithm and updated recommendations.
Dr. Oster is a pediatric cardiologist and professor of pediatrics at Emory University School of Medicine and works at Children's Healthcare of Atlanta. He also serves as medical officer at the CDC National Center on Birth Defects and Developmental Disabilities. Dr. Oster, welcome to the show.
Great. Thanks for having me. Happy to join you.
Let's start by talking a little bit about the history of the CCHD screens. When did we start recommending them at the AAP, and in what states are they currently being done?
Yeah. So, the story of CCHD screening really goes back a few decades. In the mid-90s, people first started recognizing that this simple test, pulse oximetry to detect low oxygen levels, could be used to potentially look for heart disease. And over the next 10 to 15 years, people looked at it in different facets and considered it and trialed it. But then it wasn't until about 2010, when it was really, kudos to them, some parents and advocates who pushed for this, right? The science wasn't completely there, but the parents and advocates said something must be done. And so they lobbied to get CCHD screening added to the National Recommended Uniform Screening Panel. AAP had been kind of a player in this all along and helping to provide some guidance and interpret, what evidence was out there. But it was really around that time that AAP took a critical role. And in 2011, when there was a big meeting to review, should CCHD screening be recommended? And there was a big meeting that AAP was at and helped to coordinate a number of other professional organizations, federal health agencies, advocacy groups, and researchers who all came together. And out of that came a document, the initial document in 2011, published by Alex Kemper and a number of others, really advocating for CCHD screening in newborns. So it goes back to then. That really started the ball rolling. There were some early states that adopted it, and then slowly many more states. And as of 2018, though, all 50 states in the United States now have CCHD screening as part of their recommended newborn screening panel.
So we've had since 2011 to study the outcomes and since 2018 to study them nationwide. What have we learned? Are these very sensitive or specific tests for detecting congenital cardiac disease?
So one of the first things we learned is, and we knew going in, that the sensitivity isn't perfect. When you think of screening tests, if you're taking your boards and you're looking for a criteria for a good screening test, I'll tell you, pulse oximetry is not it, because the sensitivity is actually pretty low, somewhere around 70 to 80%, depending on what you're looking at. Because there are certain critical conditions that don't necessarily have hypoxia, all right, or we're not going to detect it. So the critical coarct where the PDA is closed, they're not going to be hypoxic, and you're going to miss it. And, for coarct in particular, screening's only about 35% sensitive. So, one key takeaway that we've often told people is do not rule out congenital heart disease based on the screening test. It is one additional tool. It is not a diagnostic test. It doesn't rule anything out. Another thing, that we've learned is that, yes, we detect a number of cases of critical congenital heart disease, but we're also, detecting a lot of other types of diseases that, previously may have gone missed. So, the well baby that you described who looks great for you, have a little acrostenosis, could also have a hemoglobinopathy, could also have, some sort of infectious disease going on, just a little sepsis that's starting to brew. There are things that we're appreciating that, yes, this pulse oximetry, while the primary intent is for detecting critical congenital heart disease, it's also been useful in finding other types of diseases. And then in terms of its impact, that was a big question early on, is two things. One, how's it going to affect, the shock to the system of all these babies who are failing, and what are they going to have? And then is it going to make a difference? Well, the first thing is it has not been a shock to the system. It is not causing unnecessary echocardiograms or too many unnecessary transfers, which a lot of people were worried about. In fact, there was one study which showed that they were echoing less thanks to CCHD screening, because they felt reassured that there wasn't at least something critical in the nursery that needed to be done right away. So that's actually interesting. And then the second thing, though, for the impact, we published a number of years ago a study looking at, the impact of having legislation for screening. So this was early on before all the states had it. And we looked at the changes in rates of infant mortality from CCHD over time in the states that had legislation for screening versus the states that did not. And we were able to show that in those states that had requirements for CCHD screening, their infant mortality rate from CCHD decreased 33% more than the other states. And that was kind of a game changer. That really brought a lot of the other states and places on board that, okay, yeah, there really is a role for legislation. And many more states were able to do it. And many more countries started adopting it then too, when we were able to show that, having the requirement matters and makes a difference.
That is a great overview of how important this test is. And let's go through some of the big changes to screening that you recommend now in 2024. The first is the % oxygen saturation needed to pass. Can you tell us more about that value?
Yeah, so let's take a step back because I want to give credit where credit is due. That original algorithm that was proposed came from a study actually out of Sweden. It's actually an echosonographer who was echoing all these babies and realized there's got to be a way to figure this out and determine this sooner. And so she went and got a PhD and worked with people, and as part of her study, devised just this algorithm, kind of a back of an envelope type of thing to figure out what do we think is going to work. And they did their study, and lo and behold, they showed that what they came up with worked. Now, it wasn't compared to a lot of other things. It was just the first one out there. So our initial algorithm in the United States was based primarily on that work. And on that work, that's where the 95% number came in. Also with that was the 3% or less difference between the upper and lower, primarily looking for ductal-dependent lesions where you have, right to left flow across the ductus. So that was the initial one that was put out there. And the initial one said that you needed to be at least 95% in either the right hand, that's your preductal measurement, and, the foot, whichever foot you measure. So that's your postductal measurement. Well, in a great example of quality improvement where, not everyone's doing the same thing, but we can learn from each other, New Jersey decided to actually use a different algorithm. Now, New Jersey, they were the first state to implement CCHD screening, and they did so actually before the official AAP recommendation or the national recommendation. But they used that algorithm and they said, we want to make it easier for people. And we'll just say you got to be 95% in the hand and the foot. All right. Forget this. Oh, if it's 96% in one and 93 in the other, you're okay. And said, no, you need to be 95% in both. And so based on their experience, we showed that it actually works a little bit easier. Makes sense. And it can also potentially pick up, some more cases without a significant increase in the false positive rate. So they published their experience and we all learned from that. And so when, in 2018, we had a large meeting with many of the different stakeholders again, similar to that earlier one. And people voted on, hey, do we think we should just adopt that everywhere? And people said, yeah, that makes sense. Let's do that. And there's good data to show that it's not going to be a big effect on the system. And it may actually be easier and work better. So that's why that change was made in the latest clinical report.
Go New Jersey.
Yeah, go New Jersey. Minnesota also adopted the New Jersey algorithm, so I'll give them some credit. They adopted it earlier. Another change to the algorithm that was voted on at that meeting and accepted. There were a number that were voted on, but only 2 were accepted. One was to, only have 1 retest instead of 2. The way the initial algorithm was proposed, that the baby would get the test. It was really low. Yeah, they failed. It was really high. Yeah, they passed. It was somewhere in between. It said retest in an hour. And then in that hour, if you were still kind of in between, retest again. Well, the group thought this is just cumbersome, takes a while, and you could potentially be missing some cases, just the way that people are interpreting the pulse oximetry. So just do 1 retest. And so there was data showing that as well, that this also does not translate into a large number of extra testing that you would have to do by, calling babies a fail if they don't pass just after the second test rather than waiting for a third. So that's the one big change too. So now just 1 retest, not 2. If after that 1 retest, the baby doesn't pass, you need to institute your measures to evaluate for the cause of hypoxemia.
And are we still talking about asymptomatic healthy term newborns? To be clear about oxygen levels, I live at sea level, but I have family in Colorado and they have a much higher elevation. Are we all using 95%?
So I'll address your first question, then I'll get to the elevation. So screening was always intended for the healthy appearing asymptomatic well baby newborn. All right. And that's, if you go back to the original algorithm, it states that it was meant for well babies. Now, the question and the issue of in the NICU or in other settings, should we be screening? What should we be doing? A lot of that actually comes up because of the way policy was written. I've gotten a good education on how to write policy these last 12 years, helping states. Because New Jersey was great in that they instituted screening, but they also taught us a lesson in that their initial policy said every child needs to be screened, period. So every child in the NICU who's sitting there on oxygen for a while was getting screened on oxygen. Useful? Probably not. Every child who had a prenatal diagnosis of hypoplastic left heart syndrome and had a postnatal echo confirming hypoplastic left heart syndrome was getting screening at 24 hours. Not sure that was really needed, but to meet the letter of the law, that is what they had to do. So yeah, screening is initially meant for asymptomatic children. In this latest clinical report, though, we do address that a little bit and mention that, we recommend that screening be done on a baby off of oxygen. Right? We don't want to mask any sort of CCHD. So for the NICU, that baby who's on oxygen for a while, you can wait until they get off oxygen. It doesn't need to be done at 24 hours. They're not going anywhere. If they start having any issues related to the disease, they're going to have symptoms and you're going to see it, be able to act in the NICU or investigate it. If you can't wean them off oxygen, that should probably be a cue that you probably need an echocardiogram anyway. And you should be looking at why this child can't get off oxygen. In Georgia, we have explicitly stated in our policy that a child who has an echocardiogram for any reason does not need to undergo screening. So once you've had that, it's okay not to do it. Yeah, so NICUs have been adapting the guidelines for how they can use it and how they can also conform to their state's legislation. And that adapting is important too. There's been a lot of research, there's been a lot of studies, there's been a lot of work done and there's a lot of science behind screening. But at the end of the day, it is still a lot of expert opinion. And there's a lot of thoughts on there. And so for places who have different altitude levels, yes, by all means, adapt it to what works for your situation. Yes, the numbers can be different. And there have been a number of studies, and people from not only Colorado, but also other countries like Bolivia have been doing a lot of great studies of what does this look like in higher altitude settings. Yes, infants at a higher altitude typically have a lower oxygen saturation, according to pulse oximetry, than those at sea level. Especially those that are greater than 6,800 feet is where we've really seen a difference in literature. So some Colorado hospitals are under that, but some certainly are higher. And different places are trying different things, such as repeating pulse oximetry every 4 hours while awaiting an echo, placing a newborn in an oxygen hood to replicate sea level atmospheric oxygen tension, and allowing further transition time, so waiting for about 30 hours instead of 24. These are all just things that people are trialing, but certainly we need to eventually learn more to have real firm recommendations for at high altitude.
And we've been talking about states and how there has been variation and how much that's informed the screening. To keep all states on the same page about their CCHD screens, how should they be recording or reporting on the screening?
The recommendations for states goes back all the way since the initial recommendation of screening back in 2011. And it's certainly been a challenge for certain states. This was, a new activity that isn't always funded for them to do. To help with that, many years ago, over a decade now, was a recommended minimum data set that was proposed to collect important information such as demographics or the result of the screen and the result of the investigation. And this can help us, not only track infants so we can make sure that they're getting the screening that they need, but eventually also to help improve screening. We have this new algorithm, these new changes, but that doesn't mean that this is the end. As we learn more, we can continue to make improvements in the future. Some states have done this, and have got good examples of this, is linking newborn screening programs with the birth defects monitoring programs. Those sound like those should always be under the same umbrella, but in fact, they're not, depending on the state. But by linking those, it really allows states to detect false negative results from screening. They can find out which kids are in birth defects monitoring who are past the newborn screening, and also identify other opportunities to improve the screening process and to make sure that the kids who are identified are getting the treatments that they need.
I love highlighting this need for information sharing. Do you think these new guidelines will go a long way in addressing inequities in care infants might receive at a well-resourced academic center versus one that might not have a pediatric cardiologist on call or even nearby?
Addressing disparities is one of the great successes, I think, of this screening program. Early on, we were able to show that where this was going to have the biggest impact was the rural hospitals, hospitals where you don't have a large academic center, because they didn't always have the resources or the ability to identify children as early, especially if they didn't have much prenatal care in those areas. Right? If you can't get to good prenatal care, you can't get a prenatal diagnosis, and so that early screening is even more important. So that is one great thing, that it has been able to reduce that disparity, at least for location where you are. Another great success of pulse oximetry in reducing disparities is, by, race and ethnicity. One of the, early stories, that I heard, an early case of this is there's an African-American child who was sitting there happy as a clam, and the pulse oximetry was reading 65%. And the interpretation by the team was, this machine's broken. Send it to engineering. Get another one. Because the kid looks so good. Because cyanosis can be really, really hard to detect, especially if you have darker skin pigmentation. It's harder to appreciate cyanosis. That child ended up having transposition of the great arteries and was able to get the treatment they needed. But, having this test that can help everyone, regardless of skin tone, is great. It's a great option. Now, there are questions in the field about how well does pulse oximetry perform based on skin tone. I don't want to leave that untouched. Certainly in adults, it's been shown to actually not be as accurate in darker skin pigmentation, and there's some question about that in children. There's at least one published study and then another unpublished one I know of looking particularly at infants, however, and it does not necessarily seem to be the same case in infants. We're not really seeing that as much. We think and hypothesize that it might depend on the production of melanin over time, that, fresh out of the womb, it's not as much as later on in childhood.
These are such great insights about this report. And Matt, do you have any last takeaways you'd like to leave us with and make it something from the heart?
So my final thoughts, I would say, regarding screening is, it's been a blessing for me to be part of this, but I'm just one person out of many. It's really taken a village, from the clinicians who first noticed that this could be useful to the researchers who started looking into this as what we can learn and how it can be applied, to the health policymakers who decided to implement this as important screening, but most importantly to the parents and advocates who really pushed for this and said, you need to do something. This is not acceptable. We need to find a way to catch these babies. Personally, I have an aunt who was born with a critical congenital heart defect that I didn't even know about when I was growing up because she died in infancy. And, it would be nice if there were something like this many years ago and treatments many years ago. But we have this now. It's useful. It has been effective, and it's a great example of a public health success.
Well, Dr. Matthew Oster, thank you so much for joining us today.
Great. Thank you for having me. It's been a pleasure.
To see the new CCHD algorithm and read the clinical report, Newborn Screening for Congenital Heart Disease, a new algorithm and updated recommendations, visit our website at aap.org/podcast.
Coming up, we'll look at how having the talk can help Black families reduce stress around police interactions.
Parents have a lot to worry about. Many of us respond by having hard conversations with our children to help keep them safe.
Dr. Joseph Wright told us about one such conversation in episode 30. He described the talk he had to have with his children when interacting with police. Here's a clip.
And not only did I have this talk with my sons as they began to drive, but I have unfortunately had to model the talk, stopped while driving while Black with my sons, and in fact my wife in the car as well. These are realities. This is part of parenting and part of an approach to anticipatory guidance in the family, and certainly something that very deliberately has been a part of my approach and something that we share and teach, and I think is an element of racial socialization. This is an example of what racial socialization looks like and how pediatricians need to understand the importance of these kinds of tools.
Dr. Wright describes the talk as virtually a requirement for raising Black children in America, but is it really something that keeps them safer or less stressed about dealing with the police? That's something our next guests try to answer.
They are the authors on the paper The Role of the Talk and its Themes in Black Youth's Anticipatory Stress of Police Brutality. Rebecca Fix holds a PhD in child psychology and is an assistant professor at Johns Hopkins Bloomberg School of Public Health.
Dylan Jackson holds a PhD in criminology and is an associate professor at Johns Hopkins Bloomberg School of Public Health. Drs. Fix and Jackson, welcome to the show.
Thank you so much for having us.
Yeah, thank you so much for having us. It's a pleasure.
You heard one of the pediatricians on our show describe his talk. Becca, why is this an important conversation for Black parents to have with their children?
That's a really important question. So policing in the United States has profound and disproportionate harms on Black youth. It's really manifesting as a public health crisis that has significant mental health and developmental consequences. We know from decades of research that Black youth are more likely than their peers to experience police stops, often in aggressive or dehumanizing ways, even in the absence of legal wrongdoing. We know that these encounters, which frequently involve violence or intimidation, can contribute to heightened rates of depression, anxiety, trauma, and even diminished hope for children. Importantly, anticipation of police brutality, whether it is experienced directly or vicariously, including through social media, can really exacerbate stress and mental health challenges for children. And these harms are compounded by systemic racial biases in policing that disproportionately target Black communities and have ripple effects on academic engagement and success and trust in institutions and overall well-being. And this really underscores the urgent need for systemic reform and support for these youth.
Dylan, before your study, how much did we know about the talk and its influence on children's stress in dealing with the police?
So there actually is quite a bit of evidence that the talk can promote positive outcomes for young people, but we didn't know a lot about some specific mental health outcomes. And so for our study, we found that young people who have had the talk with their caregivers about police interactions were able to reduce their levels of anticipatory stress of police brutality. So, what that means is they were less worried about potential future interactions where they may be the subject of police brutality or where their family members or other loved ones may be the subject of police brutality. And so, this is something that we had very little evidence on in terms of quantitative data from youth themselves. And so this is actually something that's pretty new in the literature. But we do know that broadly, the talk as a racial socialization practice is very beneficial for young people across the board.
And Dylan, to kind of get into the weeds of the study, how did you get the data for this study?
So the data come from a community-wide non-probability survey of Black youth ages 12 to 21 in Baltimore City, Maryland. And so we collaborated with 12 youth-serving organizations across the city who serve diverse groups of youth, including youth who are disconnected from school and work, as well as youth who identify as lesbian, gay, bisexual, or queer. So in our sample, about 1 in 3 youth were disconnected from work and school, and about 2 in 5 youth in our sample identified as LGBTQ. This was really important for us because often these harder to reach populations are underrepresented in the work that is very relevant to their lived experience. And so this was something that we really were intentional about when we collaborated with organizations to make sure we had a diverse group of Black youth who lived in Baltimore City. And the data were collected pretty recently from the summer of 2022 to the summer of 2023.
And Becca, I mean, there's no script for the talk. So what sort of advice does it usually include? I have to imagine it varies from one family to the next.
Absolutely. And there is no set script that is the right script, which makes this conversation even more challenging for family members to have. But there are some key messages that are important for caregivers to be aware of and for pediatricians to be aware of based on our research and other work. So one thing that's really important to be noted in the talk is to balance realism with reassurance. So it's essential to prepare children to recognize that there will be potential bias when they're encountering police interactions, but that there's also many police interactions that are not harmful. And so caregivers are encouraged to share their own personal experiences, both negative and positive, highlighting the ways that they felt and being genuine in their emotional responses, as well as talking about how they coped or whether they did not cope and why. And this approach can really be valuable and validating for children who are starting to navigate this new space. It's also important for caregivers to avoid fear but acknowledge reality at the same time. So while police violence is a real concern, our data are demonstrating that emphasizing fear can be counterproductive. And caregivers are encouraged to really strive to balance this by normalizing ideas that interactions with police can really vary widely, like I was saying previously.
And Dylan, what children were most likely to get the talk? I know we touched on this a little bit already.
Yeah, so what our results show is that young people in the sample who endorsed that they had been directly stopped by police in their lifetime or had witnessed a stop in the community or in their school were more likely to have received the talk or had that talk with their caregivers. But it's not just youth who've had in-person experiences. It's also youth who had more frequent exposure to police violence in the news, as well as young people who had a wider social circle of individuals who had their own experiences with police. And so these diverse exposures to police were very strongly related to whether or not youth had received the talk. But I want to make it very clear that when we're talking about the mental health benefits of the talk, it is not necessary for young people to have had any of these exposures to benefit in terms of reducing their anticipatory stress. Because regardless of what youth have or haven't been exposed to so far in terms of police, they can still and will still benefit from having the talk because this is about anticipatory stress for future encounters, right? So even if a young person has never had exposures to police or certain types of exposures to police, they will still benefit from having this talk in terms of reducing their anxiety, their worry, and their stress about what may happen to them or their loved ones in the future.
Becca, we've been talking about the benefits of this talk. What did you learn from this study exactly about those benefits and its impact on kids?
It's really important that we focus on understanding how anticipatory stress impacts young people and whether and how the talk influences anticipatory stress, because anticipation of police brutality, whether experienced directly or vicariously through others' encounters, really profoundly impacts children's mental health. And it compounds stress in ways that are immediate and enduring. And this anticipatory stress is really rooted in an expectation of harm, and it activates for children their body's fight or flight response, even in the absence of actual threats, which of course many of us know leads to this chronic physiological and psychological wear on children. And for communities that are disproportionately targeted by policing practices, the sustained state of hypervigilance that children can be in can really result in heightened anxiety, depression, and trauma symptoms, all of which are, of course, linked to poorer health outcomes. And what's really important about the talk reducing anticipatory stress is that it can help reduce this erosion of trust in societal structures and the disruption of daily functioning that we can see, which children can do as they're altering their behaviors and choices and movements to avoid potential dangers if they're worried about police. By addressing and naming some of this anticipatory stress that children can have, caregivers, pediatricians can help reduce this perpetual cycle of fear and stress and really contribute to a broader climate of racialized health equity and collective well-being.
Talking about the talk is important, but we also want listeners to read your paper. Do you have any last takeaways they should know before they dive into it? Dylan, let's start with you.
I think the key takeaway is that when we reflect on the harms that policing has done to Black families, there's so much that can be done among these families to build safe, trusting spaces, have dialogue and conversation about the very real historical and ongoing bias in policing, and thinking about the ways that caregivers can support their children and their mental health by having these conversations that are honest and open and real, but also that don't necessarily promote ongoing fear and widespread mistrust of institutions. So it's a very important balance, and that's what our findings show, that the talk itself reduces anticipatory stress of police brutality, but that the content and the context and the messages actually matter. And it's important for parents to be honest with their children about unfair treatment and bias in policing, but also to navigate very carefully conversations around fear and mistrust. So yeah, that's what we found.
And Becca, any last takeaways from you?
Yeah, so ultimately we found that the content of the talk was significantly influential on youth's outcomes, and that caregivers who are providing messaging that's emphasizing compliance, like suggesting obeying officers' orders, staying quiet, were associated with lower anticipatory stress. And one big takeaway for pediatricians, really, that I think is essential for this audience, is that they can really work to guide families to focus on messages that emphasize safety and coping strategies rather than actions that may inadvertently increase stress. And it's really important to normalize, again, just how this conversation is so critical, but is not a natural conversation, and is something that parents and caregivers really need to prepare for and recognize as an ongoing discussion with their children.
Well, we appreciate this discussion with you. Drs. Fix and Jackson, thank you so much for joining us today.
Thank you so much.
It was a pleasure. Thank you for having us.
To read the paper, The Role of the Talk and its themes in Black youth's anticipatory stress of police brutality, visit our website at aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, Joanna, you and our long-term listeners will remember that I married into a ski family, coming from a very not ski family. So once a year, I try and go up to Colorado with my wife and our kids and all of her family and stay on the mountain. And I just have to report that I was up there for 3 days, came back uninjured. Actually had one run where Christy said she did not have to put on the brakes completely to stay with me. And I'm taking it as a win, okay?
That is great. I do not ski, so I cannot share in the enthusiasm, but I'm happy for you guys.
All I can say is it's never too late to start. I'm proof.
Well, I'll make my say something a little bit more cuddly, which is that my son and I were the only ones that were really not sick during this past week. It's been hard in viral season for a family of 3 kids who are very young. And so one activity that we did together and we left everyone else at home for was going to a cat cafe. Have you ever heard of these, David? It's where
I've passed them.
Yeah, and you just, and this cafe is really cool. It's in Philadelphia. They put the cats up for adoption. We weren't going to adopt cats. We were going to just have lunch with cats. And it was great. And we had so much fun. And my husband's allergic to cats, so he couldn't do an activity like this. And it was just a nice bonding for my son and I. We had a really great time.
Oh, that is so sweet. I love that. That is great. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel, Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll talk about evaluating children with fractures to determine if there's abuse.
We'll speak with the author of a new clinical report, Dr. Suzanne Haney. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.